Good morning everyone. Myself Deepika Jakhar, PhD scholar from ILBS New Delhi. First of all, I would like to thank the organizing committee. The title of my presentation is Increased Stool Urease Activity Correlates with Hyperammonemia and is an independent predictor of overt hepatic encephalopathy in cirrhosis patients. Hyperammonemia is a metabolic condition characterized by increased levels of systemic ammonia. It is central to the pathophysiology of HE in cirrhosis and is correlated with higher hospitalization and mortality even in stable patients with cirrhosis without HE. Now, there are certain limitations with measurements of ammonia as there is no universally accepted cutoff for normal and abnormal values, improper storage, sampling and transport. Ammonia production in health takes place from the gut with the help of urease expressing bacteria and phosphatase activated glutaminase. Ammonia clearing organs are basically liver, muscles and brain in which the glutamine synthetase activity takes place. Ammonia production in cirrhosis is increased from the gut and liver being scarce is not able to detoxify all its ammonia either through urea cycle or glutamine synthetase. So, in a study it was shown that phosphatase activated glutaminase was found to be increased 4-folds in cirrhotic patients when were compared with healthy. In another study it was shown when the conventional cirrhotics were compared for ammonia levels with germ-free cirrhotics, they found an increased ammonia levels in conventional cirrhotics when compared to germ-free. So, suggestive of the fact that gut microbiota has a role in ammonia production. Now, coming to this bacterial urease enzyme. This is the enzyme which is present in the normal gut also, but its expression is increased in the dysbiotic gut. So, no mammalian genome encodes for this urease gene. In a study, it was shown that urease activity was found to be increased in conventional flora when compared with antibiotics treated or low urease formulation. In another experiment, they showed that stool ammonia was decreased after the gut was washed and started progressively increasing after the ASF or the low urease formulation was transplanted. These are certain major urease expressing bacteria which are known to increase in cirrhosis. With this background in mind, the rationale of my study is that many urease expressing bacteria are known to increase in the gut in cirrhosis, but their contribution to hyperammonemia is not known. With this, we aim to study the correlation of stool urease activity to ammonia production and hyperammonemia. For this, CCl4 cirrhotic animal model was developed and these were the endpoints which were studied. Coming to the results, peripheral blood ammonia, portal blood ammonia and stool ammonia was significantly higher in cirrhotics as compared to the controls. When the ammonia production was looked, the phosphatase activated glutaminase activity in the duodenum, colon and kidney was significantly increased in CCl4 or cirrhotics as compared to the controls. When the urease activity in the duodenum was seen, there was no significant difference in the controls and cirrhotics. However, in the colon and stool, the urease activity was significantly increased in CCl4 as compared to the controls. Now, when the ammonia detoxification was looked in the liver, carbamyl phosphatase synthetase, which is one of the major rate-limiting enzymes of the urea cycle, was seen. CPS1 was significantly decreased in the CCl4 as compared to the controls, and glutamine synthetase activity in the liver was also decreased in CCl4 as compared to the control. However, in the muscles, glutamine synthetase activity in cirrhotics were higher than the control, suggesting of the fact that muscles behave as a rescue organ for ammonia detoxification during liver cirrhosis. Next, as ammonia clearance in the liver decreases and stool urease activity and ammonia production in the gut increases, but how? To check this, that whether increased gut urease bacteria contributes to blood ammonia, we designed another study in which 4 animal models were taken. CCl4 and control animals were gut washed with PEG 400 after overnight fasting and were inoculated with live and pasteurized Klebsiella pneumonia, which is one of the major urease expressing bacteria, for 7 days. And these were the endpoints which were studied. Stool urease activity significantly increases in both control live and cirrhotic live when compared to their pasteurized counterpart. However, stool ammonia and plasma ammonia were only increased in cirrhotic lives and not in controls. This suggests that stool urease activity contributes to hyperammonemia in cirrhosis not in controls. Next, after this experimental study, clinical study was designed that can we use this stool urease activity as a surrogate marker for hyperammonemia in cirrhosis? For this, we aim to investigate the stool urease activity as a predictor of HE in patients with liver cirrhosis. In this study, 12 healthy control and 30 cirrhotic patients were employed and their blood and stool was collected. Cirrhotic patients without HE were included in the study and 12 patients developed HE within 6 months and there were 8 deaths. Stringent sample collection and storage of sample was done and urease activity and ammonia estimation was done within 1 to 2 days of the sample collection. We took age and sex matched healthy and cirrhotic patients. Disease parameters like bilirubin, AST, ALT, creatinine, serum sodium, INR, serum albumin was increased in cirrhotics as compared to the healthy. There was no patient with overt hepatic encephalopathy at baseline. Now, the crude ammonia was measured to normalize ammonia levels by taking a ratio of serum ammonia to the reference laboratory upper limit of normal for ammonia, and we found out that normalized ammonia and stool urease activity was significantly increased in cirrhosis as compared to healthy. Normalized ammonia and stool urease activity also increased with disease severity, CTP class. We found a positive correlation between stool urease activity and normalized ammonia, and this is the equation for predicting ammonia from stool urease activity. Normalized ammonia and stool urease activity was also increased in patients which developed first episode of overt hepatic encephalopathy in comparison to the patients without OHE. Normalized ammonia and stool urease activity was also higher in non-survivors as compared to survivors. We also did univariate analysis to see the independent predictors of overt hepatic encephalopathy in patients with cirrhosis. Stool urease activity, serum ammonia and MELD sodium came out to be significant predictors of overt HE. However, in the multivariate analysis, stool urease activity emerged to be a significant independent predictor of OHE with area under the curve as 0.86. The cutoff value 15.25 was used as a value to predict overt hepatic encephalopathy with sensitivity of 75% and specificity of 77.8%. The summary of my presentation is that cirrhotic patients have increased stool urease activity and ammonia. The animals in which the gut was washed with PEG and the urease bacteria was inoculated, we found out that stool urease activity contributes to hyperammonemia only in cirrhosis and not in controls. In cirrhotic patients, stool urease activity significantly correlated with hyperammonemia and independently predicted overt hepatic encephalopathy in patients. Being more stable than ammonia, stool urease activity is a promising biomarker for HE and needs to be validated in larger clinical studies. The limitations of our study: stool urease activity estimation at the time of HE were not done. Changes in stool urease activity with response to treatment of HE and simultaneously correlation with ammonia levels were not done. We have a limited sample size, so the study needs to be validated in larger sample size. With this, I would like to acknowledge my team of liver physiology and vascular biology lab, MCM, ILBS, Dr. Savneet Kaur, Dr. Shiv Kumar Sareen, Dr. Shastri, Dr. Guresh, Dr. Dinesh Mani Tripathi, and my colleagues Pinky Juneja and Aarti. Thank you.
May I? Good morning.
Good morning, sir.
Excellent study, a lot of work. What do you think about your choice of measuring ammonia in serum in preference to plasma? Because my understanding is in making serum, a lot of ammonia being volatile just goes away out of the blood.
So, sir, before starting the study, I read few studies that whether I can do it for serum or ammonia. But there were like ample number of studies in which serum ammonia was also estimated, and also, yeah, I will agree with the fact that ammonia is a labile gas, so that is why I also showed in my study that it was done within like 1 to 2 days or same day estimation was done.
Even before you centrifuge and get plasma, it will go away. Because I saw that you said that from the blood sample you prepared both serum and plasma. Then why not use plasma? Your slide said that you prepared both serum and plasma.
Yes, sir. So that was done. But I did with plasma after reading before starting.
Thank you.
I read studies.
think there is one more limiting factor is associated H. pylori infection,
Yes,
because
sir.
that also elaborates the enzyme. So you can get a false positive test in H. pylori infected patients.
So yes, but H. pylori is also like one major urease expressing bacteria, and in this study we are looking for urease activity only, either it be with stool or with like intestine, like mainly the colon part. So yes, we are considering trying to consider actually at least all the bacteria which are urease positive.
Dr. Deepika, excellent study. You showed that elevated stool urease did not lead to elevated ammonia in healthy patients, but it led to increased ammonia in patients with cirrhosis. So, does that mean there would be a certain proportion of cirrhosis in whom, despite having elevated stool urease, you may not have elevated ammonia? So, what do you think? What would be the predictive value of stool urease in this setting?
No, but I didn't show that in healthy there was increased ureate but not increased ammonia. Yes, in cirrhotics there were. So I believe that if there is increased stool urease activity, there will be increased ammonia as well.
Okay.
So, Dr. Deepika, one last question. Very interesting study. So, I'm just curious to know, like you started with a broad aim of saying that the cause of increase in urease expressing bacteria and the link between hyperammonia anemia is not known. So, are you suggesting that expansion of the urease expressing bacteria somehow causally linked to hyperammonemia as well, or are you suggesting that there is just this association and as a surrogate marker?
So, oh ma'am, we are suggesting it as a surrogate marker. I believe that if there will be like more urease expressing bacteria, there will be increased ammonia.
Okay. Okay. So do you have data to support that?
Yes, ma'am. Increased urease, yes.
Okay. Okay. Thank you.